Good day, and welcome to Epstein, Becker, Green, and EBG Advisors webinar, How Health Information Exchanges Are Supporting Population Health Management. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 3 fantastic speakers today. Epstein, Becker, Green's Patricia Wagner, who is a member of the firm in the Healthcare and Life Sciences and Litigation Practices in the firm's Washington, D.C. office. Lee Barrett, Executive Director, Electronic Healthcare Network Accreditation Commission, and Irene Koch, Executive Vice President and General Counsel of HealthX, Inc. At this time, I'd like to turn the webinar over to Patricia Wagner.
Thank you, Whitney. And as Whitney said, we are very excited about this webinar today, or at least I am, because I am very interested in this area. We have 2 great speakers. Lee has a lot of experience in the healthcare world for a variety of organizations, both in the services organization side, the payer side, and also on the provider side. So he has a great background. Currently, he speaks nationally on a variety of e-health and e-commerce issues. He's involved in a number of industry coalitions promoting the use and implementation of both administrative and clinical transactions, including development and proliferation of electronic health records and meaningful use. He continues to work on key e-health industry initiatives that lay the foundation for health information technology, including support and implementation of the American Reinvestment and Recovery Act, HITECH, and HIPAA. So we're very excited to have Lee here today. Our other speaker, Irene, also has a very impressive background. She's, as you note, the Executive Director of a Health Information Exchange, and in that role, she oversees the activities, the strategic initiatives, looking at the expansion and the presence in the HIE landscape. She has expertise in privacy and governance issues as it relates to electronic exchange of community-wide health information. In addition, she's a member of the Policy and Operations Council of the New York eHealth Collaborative and a frequent contributor on issues related to health information technology transformation. So with those 2 speakers and that terrific background, this presentation, we're going to cover a lot of material. We're going to look at how HIEs can be used to support population health management and coordinated care efforts. Here's some lessons learned, both on a regional and a national perspective. We'll be thinking about current issues associated with HIEs, including the sustainability of them, privacy and security issues, and data integrity. Hopefully, we will be able to enlighten all of you on some of the great benefits of HIEs and how they can be used in a population health management arrangement. And with that, rather than going on, we'll turn it over to Lee to start the process.
Okay, great. Thank you, Trish. I appreciate it, and thanks for the introduction. And hello, everybody. So I'm going to try to take us through really looking at the different exchanges, including ACOs. I'm going to talk about HIEs as well. We'll talk about the direct project and how that's as well affecting the whole aspect of security and privacy of the exchanges, the direct trust and ENAC relationship, and I'll talk through some of that, as well as the ACO side of this as we're talking about various exchanges. So we'll hopefully talk through and give you a pretty good broad context before turning it over to Irene, who's really going to talk as well more specifically regionally about what they're doing as well in New York, and they're doing some very exciting things. Next slide. So let's talk about, next slide, please. So there are a variety of different models that are out there. We've got, health information organizations, health information service providers, which are the HIEs, EHR vendors, the hospitals, the ACOs. There are a lot of different organizations and certainly various sources that are all involved as stakeholders as we're looking to build and who are involved in the HIE proliferation in the market. Next slide. So as we start to talk about some of the truths that are actually out there, first of all, it is definitely a journey here. I mean, as we look at how these models are evolving, there isn't one model is not necessarily the same as another model. They're all, in many cases, very different. There may be certain aspects in which they are the same, but we're continuing to see evolution in all of these models as they're proliferating. We've got the government, obviously, that's being involved and helping to, I would say, create the roadmap here, and I'll talk a little bit more about what we're seeing ONC doing as the Office of National Coordinator in trying to put together an overall roadmap for the industry for really the development of this nationwide health information exchange network that's evolving. It's definitely not a one-size-fits-all. As many of you who are involved in the proliferation and the evolution of these HIEs and these various exchanges, they're very different, and they've got a number of different entities and stakeholders that are involved with them, and so the needs and some of the requirements are different. The metrics in many cases may be the same, but how they get at some of that information may be very different. And it's evolutionary, as we've talked about. There's a lot of incremental steps to get there, and every single model is somewhat different, and they all have excellent benefits. It's just some of the benefits may be different from model to model. Next slide, please. So as we talk about some of the issues that are certainly affecting the HIEs and the ACOs today, we've got the omnibus rule, and so any of whether it's at the federal or the state, healthcare legislative issues are absolutely, from a compliance standpoint, a key determinant and a factor that all of these various exchanges need to keep in mind and take into account and develop the policies, the procedures, and the controls to be able to manage the risks. The Office for Civil Rights, as many of you are aware, in 2012, started doing audits in the industry. They've continued to do audits in 2013 and 2014, and when they developed the omnibus rule, they continue to make other changes to the audit protocol that they're using. We worked very closely with them in 2013 to align a lot of the criteria that we're using in our programs, our accreditation programs, to assure that we had all of those capabilities and all the functionality that they were looking to include into our accreditation model as well. In 2015, based upon what I've seen over the past couple of weeks, they have not as yet looked to start really the audit reviews in 2015, and not sure when they will look to do that, but they're continuing to develop and certainly take on that enforcement role. Next slide. Next slide, please. So we're going to talk about kind of how ONC is playing a role here, and what ONC is coming out with next week, and they've continued to work on this, is they're having their annual meeting next week in Washington, and I've seen and have been involved with the development of the roadmap that they're putting out in relation to the nationwide exchange models and how this is going to proliferate through 2024 as they've laid it out. They've laid out some incremental steps for the industry to actually achieve during that period. And so as we're going to continue to see the models evolving and various aspects on those models continue to evolve, they're definitely, and many of you probably want to take advantage and take a look at what they're laying out as far as an overall roadmap. The whole aspect here then of kind of the governance infrastructure, the trust framework, it is all part of what they're putting in place here. The federal government and how the federal government is going to continue to play a role from a standpoint of funding some of these various initiatives will continue to be there, but we're also seeing some, I would say, changes that are occurring in some of the funding areas. And best practices are clearly being shared, I think, at the ONC forum next week and some of the other forums that I'm seeing as well. There's a lot of good work, a lot of good case studies and information that are being shared, I think, between various stakeholders. HIMSS obviously is another good forum for that sharing of information. So, you know, and then you start to look at how meaningful use is playing a role in evolving. All of these really become, I would say, building blocks for the evolution of the nationwide exchange models. Next slide. So as we continue to look at this, we're also seeing a lot of regional efforts that are going on, as Irene's going to talk about what New York is doing and others. I mean, we're seeing some very excellent regional models and some very good data that's coming at the regional level that's factoring into how the national model is developing. And I think as we're looking at these various forums and getting all the stakeholders really collaborating and sharing of information, we're continuing to see a lot of the analytics, a lot of the reporting, the care coordination, kind of population health. All these aspects are continuing to evolve in a very positive way. Next slide. So when we start to look at kind of the whole balance here, I mean, there's the cost side of this that is very significant. We've seen ONC, we've seen the federal government, as well as a number of the states and regional helping to fund some of these initiatives. And then all of that needs to be leveraged and kind of weighed against the value and the trust side of the spectrum. So we're continuing to see, I think, payment models, various payment models as well, continue to evolve, and as well as the whole aspect of privacy, security, confidentiality, as we're seeing more consumers, the whole aspect of patient portals and other ways in which information is being exchanged. The need to create what I would call trust information exchanges and trust environments is very critical. So we're seeing a lot of this evolution occurring as we're getting more and more data and more experience, I think, with the various models. Next slide.
And Lee, if I could interrupt, just given
sure.
all of the moving pieces, if you had a crystal ball, how would you expect all of these strategies to evolve in the next couple of years?
Well, you know, I think first of all, with ONC setting out the roadmap, Trish, I think that's going to be very important. I think that provides a framework for how the various stakeholders not only collaborate, but setting out specific guidelines and specific goals that need to be achieved. Whether or not it's how we look to secure the networks, the use of direct for authentication, as well as encryption of data between various exchanges, the whole aspect around the various payment models and how the payment models occur, the metrics. I think that roadmap will be very important, and I think as well gaining the feedback and input from the various exchanges that are occurring at not only at the regional but at the federal level also will help to evolve this, and we'll be able to, I think, create kind of that building a block approach to get to the end result of what we're trying to do over the next several years of really an interoperable, scalable, and trusted set of exchange networks. So that's kind of my thought on how it's going to evolve as far as the strategies.
Great, thank you.
Okay, next slide. So, next slide. So what I'm going to talk about now is kind of I've briefly mentioned the whole issue of direct. We, ENAC, formed a partnership with directtrust.org a couple of years ago, and this is really as a result of ONC moving forward and putting together what's called the Direct Project. They developed a very significant white paper, had several work groups working on the issue of direct to really secure the exchanges and create an authentication model between the various stakeholders. So this is really, the Direct Project is really about the direct communication between all of the various stakeholders and doing it faster, more secure, and less expensive. So this really comes down to simple, secure, and scalable standards-based way for exchange of information. Next slide, please. So some of the key issues that we're dealing with is really this has to do with sending email over the internet. And with an email, I mean, you can include clinical data, there can be other types of certainly proprietary data and PHI included. So what they wanted to do is to look at the way in which these what are called health information service providers, which are HIEs, will create the exchange and be able to authenticate between all the various entities. And the intent was to try to minimize, I won't say eliminate, but minimize the number of contracts, bidirectional contracts, that these organizations would need to set up between themselves, because that's really not a scalable model. I have a slide that will show how difficult that is based upon the numbers, and if we're trying to get to scale this very quickly across the industry, it's a model that can't work with setting up different contracts. But if we do it through this type of trusted environment, then we can look to scale much faster. Next slide. So this is the slide I was talking about. If you can see the one on the left, the bidirectional contracts model, you see all the various connect points here, and this is an example where you've got 8 different health information service providers. This now requires 28 contracts, bidirectional contracts between all those various entities to make that work, to exchange data. You compare that to the right-hand side, which is the single accreditation model. So now you've got those same 8 health information service providers, or HIEs. It now only requires 8 accreditations, and once those accreditations are in place, any of those entities can exchange information and data between them because they can authenticate. They've already been, quote, trusted in relation to the database or the trust anchor bundle that directtrust.org maintains, and so they can, they're authenticated, they can send information between them very quickly. The authentication's already been done, and they can now encrypt the data from point A to and decrypt it on the receiving end. Next slide, please. So as we're looking to do this, you know, and as the industry looks to this, one of the keys is whatever we're going to put in place has got to be very scalable, and it's got to be very easy for organizations to implement and not create, you know, the one-off contracts with each other, which is going to take a long time, be very costly, and there's no way which we'll be able to get the type of interactions and the connection points that we're trying to do very quickly. So it becomes, as I indicated here, really a rate-limiting step. Next slide. So when we talk about scalable trust, it's really that direct exchange between all the various endpoints and really using these HIEs and the users and subscribers. And so we think that we've created through this network that and this protocol that ONC has developed and directtrust.org and the industry is adopting will help to create very quickly, I think, the network that we're looking at voluntarily so that we can scale this very quickly and get really the network effect that we're trying to do with all these various connection points between various stakeholders. Next slide. So the framework here, the direct trust framework, is about kind of three different pieces. One is the X509 certificate policy, and so there's a whole certificate authority that's part of this. You've got the accreditation program, which ENAC and Direct Trust has developed, called the Direct Trust Agent Accreditation Program, or DTAP. And then what Direct Trust has is they have a trust anchor bundle database in which any of the entities that are accredited are put into that trust anchor bundle database, and they immediately, if an entity who is accredited wants to now authenticate to another entity that is accredited, and they can easily see who is in that trust anchor bundle database, they can immediately start to send information because that entity has already been authenticated, and they can start going through the encryption between those 2 points or multiple points. So that starts to get the scalability that we're looking for in all the various HIEs and the exchanges out there. Next slide, please. So this talks about really kind of the fact that there are three different components to this. You have the HISPs, the Health Information Service Providers, the certificate authorities, and the registration authorities. And to the right there, it goes into what each of these stakeholders is performing and how they play a role in really creating the type of trust environment that we're trying to get to here for not only HIEs, certainly, as well as the ACOs and various other types of exchange models that are evolving. Next slide.
Lee, sorry to interrupt again. I'm just curious, how well has the industry been adopting the direct trust framework?
So I think, overall it's been going very well. The numbers of organizations that have, in fact, gone through the accreditation over the past 2 years has gone up pretty exponentially, Trish. We're getting, as well at the federal level, we're getting a number of the federal agencies that are also recognizing and adopting the direct, and we're in conversations with them in which they're also going through this. There's also another component called FedRAMP, in which the federal government has developed their own infrastructure for as well authentication, and between FedRAMP and the direct protocol, we're seeing a very strong, really, adoption both at the federal level as well as in other public and private sector entities in adopting that. So it's going very well, and we're seeing more and more entities that are, it's becoming a de facto standard. I think with ONC's involvement and support, it's absolutely helping the industry to migrate and evolve here very quickly.
Terrific.
Thanks. So on the ACO side here, as we're talking about kind of the ACO piece, let's go to the next slide. So the model here is we've got, you got multi-specialty groups, you've got integrated health systems, integrated providers, physician hospitals, and you've got a variety of different stakeholders that are involved here. Interoperability becomes key as far as creating the capability for the exchange between all the various stakeholders and the investment. Basically, it's both in short and long term in relation to how we need to invest in the development and how we need to set realistic expectations on how these models will continue to evolve. Next slide, please. So as we start to look at the benefits across the spectrum, you've got obviously the member side of this and the benefits there, the patient component and the use of mobile patient education, instant messaging, the whole aspect of alerts, all of that becomes important as part of how we look to engage the patients here. Overall productivity, real-time access to information, as well as being able to measure the variation across different providers, and then the whole financial side, which really looks at the whole aspect of the metrics and monitoring and analyzing the various costs. And I'll talk in a minute. I've got a slide about some of the the benefits that we're continuing to look to measure on the ACO front. Next slide. So as we look at the transformation here and how ACOs as well as the HIEs continue to provide kind of a transformation in the industry, you look at this across the bottom of stage 1, 2, meaningful use. You look at this as well across and stage 3 and where that's going to be going. And then you look at this in regards to not only the technology, the information accessibility, how we're looking to develop and to monitor and analyze the information that we're gathering, and then utilizing that information transformatively as we're looking at this from the standpoint of population health and the various metrics there. And I know that Irene's going to talk about some of these aspects as well and how they're doing that in New York and what she's seeing nationally as well. Next slide. So some of the potential savings, as I talked about before, there are several areas, and there are a variety of, and there are more that are continuing to evolve. But one looks at, the reduced number of bed days per 1,000 members. Basically, we're seeing 40% reductions there. The cost savings per member per month for those engaged in case management. The realization of per member per month reduction and utilization reductions at 13%. Commercial beds per day per 1,000 decreased by 11%. So these are some of the potential savings that certainly from the metrics that are being developed and all the data, best practices that are being developed and generated, we're seeing some real savings across not only on the ACO side, but certainly on the HIE as well. Next slide. So as we're looking at HIT and health information technology and how it's become an enablement, we're looking at that across kind of not only the connections here, where we're moving from paper to electronic, the whole clinical message exchange, the use of portals and apps for mobile, from a mobile perspective, and then the collaboration as well between care and the health information exchanges, all of which are creating kind of an overall continuum. And then you've got all the various stakeholders and how they are exchanging data through that, really that interoperability platform has become key. So we're continuing to see a lot here. The whole mobile side is very significant, where we're seeing over 1 million different applications, healthcare applications from a mobile standpoint, smartphone being developed. The big issue there is as we're seeing the proliferation of all these different applications for smartphones, we still need to look at the issue of securing some of those apps as well and some of the issues surrounding that. Next slide. So as you look at the workflow, and again, you've got all the various data sources on the left, the workflow itself, the information exchange, the exchange side, the data warehouse, the analytics and how those are being developed and created, and how they're driving really the provider-patient engagement, the various communication channels that we're using to really send and exchange information with all the various stakeholders, which are on the right. So it really does start to put in play really and create the type of environment where we're seeing an interoperable platform, and we're seeing the exchange between all the various stakeholders, which is really key to this. Next slide. The analytics for here, and again, we're seeing some of this as well on the HIEs as well. You've got the quality metrics, you've got utilization reporting, the predictive modeling that we're seeing, the financial reporting, as well as the dashboard views for all various stakeholders, so that we're taking all this data, and we've got a lot of data, we can provide a lot of different views on this data, but we can put it and we can determine exactly what types of data each stakeholder needs to see, with the capability that if they want to review or look at other data views as well, they have the capability to do that. But we've got the analytics suite that all of these exchanges are now starting to provide, and the reporting whether it's the CMS to ONC, whether it's at the state level, at the state or federal level, we've got the capabilities to do that. Next slide, please. Next slide. So how's ENAC playing a role in some of this? So we've taken the stance that we're trying to create, and we have created a variety of programs focused on the various exchanges. And so we were founded in '95. We're a not-for-profit organization. We're federally recognized as a standards development organization. We just received approval by the Drug Enforcement Agency in December for our e-prescribing for controlled substances, certification for e-prescribing networks. We've got over 100 different organizations that have gone through and who are accredited. We've got various states that have adopted different accreditation programs that we have. We've got 14 different commissioners that represent all the various stakeholders in the industry, and we're really focused on really peer evaluation and promoting quality service and cooperation, open competition between all the various entities. Next slide, please. So what we're focused on is really trying to create that competitive advantage and differentiation between all the various entities that are providing services in the 4 exchanges and the development of exchanges. We're providing that framework of reusable policies and procedures, best practices, and in improving really business processes and workflows. We're providing as well in the criteria that we have in our programs all of the metrics and the capabilities to be able to not only create those metrics, but also sending and receiving them and really focusing on overall customer satisfaction. Next slide, please. Quality, the quality of the data, the products and the services, focusing on cost reductions and helping organizations to achieve really the benefits that they're looking for, and then as well to achieve compliance with all the federal as well as state regs having to do with health care and compliance, whether it's HIPAA, HITECH, ARA, ACA, all those various aspects. And so the key is we've incorporated all of this, and we're continuing through our various committees, continue to have the industry involved as we continue to develop and enhance all of our programs. But we've had a major focus over the past 5 years on really developing a set of accreditation programs for all the exchanges. Next slide, please. So our process is really all online. You can start from a pre-application. You can go online and go through the whole application process. There's a self-assessment and then a site review that organizations go through, at which point when they will achieve full accreditation, and they have up to a year to go through the entire process. So we've created this model, and it's easy. So if you go on to enac.org, you'll be able to see all of our criteria, all of our programs are downloadable, so you can, it's kind of an open book test. You can see all the information before you actually even apply. Next slide, please. So what we've created, these are just some examples. We have a program for HIEs called our HIE accreditation program. The state of Texas has adopted that program for all of the HIEs in the state of Texas. We've also created an ACO accreditation program, and our ACO accreditation program, some examples here, we've got over 40 different specific criteria that we've developed here. We've developed instructional guidance and samples of the various types of evidence that we're looking for documentation that organizations need to provide. And we're finalizing basically this week version 1.0 of that program will in fact be released. We've spent about 9 months developing the program with a number of organizations who have provided really subject matter expertise to develop it, and we've had several beta organizations as well providing input over that period of time to get to the point where we have this version 1.0. Next slide. Some of the examples here, again, privacy, confidentiality, and breach. You can see we're focusing on encryption, authentication, as well as breach notifications here, and the whole aspect of PHI. So we're all about really creating stakeholder trust throughout the entire program here. This is a major focus for any of these programs. Next slide, please. Also, some of the other aspects that we're focusing on is having a formal operating agreement, participation agreements, the whole policies, procedures, and controls, the whole aspect of consent, which is very important in any of these models, and providing the capability for patients and consumers to be able to opt in, opt out very easily, are all key parts of what we're looking at in relation to the criteria that we've put together. Next slide, please. Sustainability and termination of operations. Again, we want to make sure that there's an overall process in the event that an ACO or an HIE were to cease operations. We want to see and make sure that they have an overall plan, evolution plan, succession plan of how they would look to evolve. So again, to minimize any impact to those stakeholders that are using and have come to rely on that particular exchange. So these are some examples of really what we've put together as far as our criteria. We have similar criteria with our HIE. We have the direct program as well with direct trust. And so this kind of gives you an overall feeling for what we're doing and focusing here, at least from an industry perspective. Before I kind of turn this over next to Irene to talk about what they're doing in New York. So that's it.
Thank you, Lee. That was very interesting, and the ACO criteria, that's a great idea. I know a lot of ACOs are created, and then, you know, everybody almost gets brain freeze for a minute. They're like, okay, now we have the ACO, what do we do with it? So that's terrific. To get into the weeds, really into the engine of how all of this is really going to work, let's hear from Irene. She can talk to us about HIEs and how the information is going to flow, which hopefully makes all of these goals achievable.
Great. Thank you so much. Can you hear me?
Yes.
Great. Just checking. So thank you, Lee, for that really comprehensive background. And as Trish just said, I think it will be a great jumping off point for hearing about RIO, One Health Information Exchange, which has elements of what Lee talked about in terms of the actual HIE function, and also a lot of parallel functions to an ACO, and we're also supporting ACOs. So I think that was a really excellent background. So HealthX is actually a regional health information organization, a RIO, and thank you. And we actually have a health information exchange, which can be a noun or a verb, as many of you may have heard, and we sort of do both. We have the technology and we facilitate the transfer of information. And that is actually our goal as an independent non-for-profit and a mission to improve clinical outcomes and promote efficiency and quality and reduce healthcare costs. So having been around in various forms and subject to merger, we now have records of over 10 million people and unique individuals, and a technical infrastructure that has evolved and continues to evolve, as Lee alluded to, over time, which is a really important point, because when we first started 8 years ago, the focus was really on some of those pictures that Lee showed you in the beginning to try to get the data just together. And as we've evolved to support the more sophisticated uses of the data, we are finding increased need for analytics and that sort of thing. And so our technology was first deployed to have an electronic master person index from IBM Initiate that links data from multiple sources on a probabilistic algorithm together to create a patient-centric view, and in health information exchange infrastructure from InterSystems that was kind of a federated model that you might have heard about. Even if it was in one central place, it still wasn't aggregated in a central database, and the databases are increasingly necessary for the analytics that our clients are needing. So that's something that we'll sort of weave into the conversation as we go further today. Next slide, please. Quick overview of our service area. Thank you. This is a map of Long Island and the New York City, and you can see from here the many long-term care and hospital facilities that we have across the area. Overall, we have 148 participants representing almost 600 facilities but they're not only hospitals and long-term care facilities feeding data into and using data from HealthX. We also have physician practices, federally qualified health centers and urgent care facilities, behavioral health organizations, community-based organizations, which are so increasingly involved in collaborative care models, and also health plans, and now also health homes, organizations that have, and collaboratives that have developed in New York State under the Medicaid program. Next slide, please. In HealthX, we have on the left side of this slide a list of some of the types of data elements that we get fed from different kinds of our participants. Not everyone feeds the same combination of data, and we are mostly able to accept everything that folks want to send to us, and those standards by which we've been receiving them and interacting with those records that feed us have evolved over time and will continue to. We have mostly clinical data, a little bit of claims data, and from most all sources we have their encounter information and demographics, and usually a consent value, which I'll talk about later. But we are also getting lots of other kinds of new data to support new types of collaborative care models like plans of care and care plans. On the right side of the slide here, it's just a very quick overview list of the kinds of services that we do support and offer to our customers. Some of these are in the product that we've bought, some of them that we have developed on top of that platform, and they evolve very much so over time. So let me just review them very quickly so you get a sense of what we do offer. So the first bullet is to get the data into HealthX from the sources that have electronic health records, and then to get the data out of HealthX. Sometimes that happens by single sign-on. And there's so many different ways we can integrate, but we do perform those integrations to get the data into HealthX. We also have a whole layer of consent management, which I'm going to talk about in a little bit. One of the first functions that we supported was this concept of patient record lookup, having a query come from a user or a system and having the ability to feed back to it, subject to consent, an aggregated record on that patient from across the community. Sometimes we also sync up systems so that the query is done behind the scenes to enhance the workflow. We have secure messaging and increasingly through direct that Lee talked about. We also have clinical event notifications, which because we're getting fed real-time data, we're able to serve up real-time alerts to users in a lot of different ways, which I'll talk about a little bit more later in some details. And increasingly, we are providing a lot more reporting and analytics services from things as mundane as usage and numbers of consents to much more sophisticated reports. And of course, in the process of doing this, we do a lot of consulting. Next slide, please. So New York's landscape is, for health information exchange, is incredibly supportive. We are really at the forefront of many states in having invested millions, hundreds of millions of dollars to support health information exchange and now supporting programs that are going to utilize that. One of the things that has evolved over time in New York is this concept of formalizing the standards to exchange data in the state to create a network of networks, or the State Health Information Network of New York, which we call the SHINY. And the SHINY standards involve technical components, operational components, member services components, and privacy components, a little bit like what Lee referred to as some of the certification standards that ENAC imposes for its ACO accreditation, and some of which relate more to the technical standards for the HIE technical accreditation. So right now, the RIOs are in the process of becoming qualified and certified that we meet these standards under a proposed regulation that's pending in the state from the Department of Health now, which we are contractually bound to comply with in the meanwhile in order to receive the state funding that we have been receiving under the state budget since the early in this year. And that is a very rigorous process that all the RIOs in the state, as you can see here, are going through. And only when the RIOs become qualified will we be able to share data between and among ourselves. So this is New York State's way of allowing the SHINee to develop is to make sure there's this fabric of trust that will be embodied in becoming a qualified entity. Next slide, please. So Lee talked a lot about, sort of this concept of a trust environment, mostly with respect to direct, but as you've heard from the regulations that I referenced, the aggregation and use of data in any RIO and throughout the SHINee is really all about trust, and we are subject to not only some of the parameters that Lee talked about, but a lot of things that are particular here in the way we operate. So there's, of course, federal law and regulations, and I've just listed HIPAA and SAMHSA here, but there are so many others, including the ones that Lee talked about related to direct. There are New York State law and regulations, not just the proposed SHINee regulation, but lots of laws and regulations to navigate with respect to consent, in particular consent laws for HIV and mental health data as examples. We have the SHINee policy and the emerging regulations that I referenced. And importantly, we also have our participation agreements and business associate agreements with our participants that give us contractual obligations on top of these policy and legal requirements. And as part of that, we also have our own RIO policies, which generally track the SHINee policies, but also might embody some additional obligations that we decide on after discussing them in our committees. And also sometimes there are contractual arrangements between and among our participants that allow them to share data together and sometimes impact what we're able to do to help them facilitate the exchange and leverage our community HIE. Next slide, please. So as I kind of alluded to, we have a real need to provide a lot of transparency and a lot of trust for our participants so that they continue to use this resource that we're able to offer to them. We really like to engage our stakeholders, not only to say here's what the SHINee policy requires of us and that will be certified, but really to give them transparency to what HealthX is doing with the data, both from a security perspective and a privacy perspective and a technical perspective, but also how each of the participants is using data to support their initiatives. And sometimes as there are novel workflows and use cases that come our way, we like to really make sure that the community is aware of them and that our users have a chance to understand how their data will be used and give it the thumbs up if it's a little bit of a stretch from our policy. So we do have many policies that meet mostly, many committees rather, that meet mostly on a quarterly basis. We have privacy and security committee. We have data governance, very much related to privacy, but really taking a deeper dive on the standards for data sharing. Clinical evaluation committee, we have a CIO and CMIO committee that does tend to be focused a lot on technical aspects. And we have a research committee when we're supporting research projects with our technology. The HealthX board approves major projects and any amendments to our RIO policies and our participation agreements. And as I alluded to and is very, very important, the SHINee funding that we're getting from the state now, sort of in the model of a public utility, comes along with evolving data use standards and other requirements. So there will be continuous change and improvement in how we do things and what the statewide standards are, and frankly, what where the zeitgeist is going with some of this, not to mention the laws. Next slide, please. So I thought it would be helpful to just level set on how we think about the data flow and the legal structure around how we even get the data in the first place in New York, in our RIO, so that everyone on the line can really get a sense of where we're coming from. It's very different in some other states and some other models, but just for purposes of getting us all on the same page, I thought I'd spend a little while just describing this to you. So all of our participants, when they want to take part in HealthX, either give us data and get data from us or one or the other, do sign a participation agreement. so that they agree to follow our and the policy standards of the HIEs and other contractual obligations, including insurance, indemnification, things like that. And they also designate Healthics as the business associate of each and every one of themselves. So we have a business associate agreement with each of our participants that allows us to hold and aggregate and exchange the health records based on our policy, consent policies, which allow sharing under consent and exceptions and by law. So next slide, please. So that all sets the stage for this notion of consent, which pervades really everything that we do. We only have the data in order to aggregate it. We can only really give it out and do things with it if consent and contracts allow us to do that. So in New York, we have developed, after a lot of discussion of many years, and this has been in place for many years, an opt-in or affirmative consent model, which can mean, even that can mean different things in different states. But in our state, patients grant or deny consent to allow their providers or one participant at a time to access community-wide health information and to receive clinical event notifications from the community. They do it by a facility basis. Sometimes the consent can be effectuated. Some RIOs have done this, we have not, through a centralized model where the patient can grant or deny consent to multiple providers at one time, say yes, yes, no, no. And now our model has really evolved over time to also require a patient to have an additional choice for an affirmative emergency choice for emergency access, which I'll talk about on the next slide. But suffice to say that we've received over 1 million, I think it's actually close to 2 million affirmative consents from patients for individual facilities in the greater New York area, but there's still a long way to go. And there are definitely exceptions to when consent is required, like for public health and some one-on-one type of facilitation. But it's a very, very important concept here in New York. Next slide, please. So this is our best implementation model of how consent works. And I'm sorry, it actually says BHICS on this slide, but this is the same model we had in one of the RIOs that merged into Healthics now. We collect consent, like I said, on a facility-by-facility basis, and the patient can decide different consent values for the different facilities. So as I was saying just before, in this model, the patient could grant consent or give consent to the middle organization with the green arrow, and all of the users at that organization would be able to see data from anywhere the data came from. Sorry about that. So in this model, in the top picture is the blue organization. The patient would have said yes, sorry about that, and the data flows from all the other organizations. And in the middle picture here, the green arrow, in this case, the patient would have probably been undecided here, or sorry, denied consent. The colors are not working on this. So anyway, you get the idea. You can either say yes, in which all data flows, no, in which only data from your own organization flows, or undecided, where you could have a one-time access to your data. Next slide, please.
Irene, just to interrupt for a moment, I know in working with providers, this consent issue is often the one that has them tearing their hair out. You know, how to get consent, what to do, how do I know if a patient has consented or not consented. Do you envision that this consent model will evolve over time to in some way, either to a more uniform system or more patient-centric system?
Yeah, in fact, it's a great question. It already is evolving. So we have some already kind of changes to this model or fill-ups to this model that are applicable to health homes, where the health home entity in the middle, sometimes we like to call it the mothership, collects consent for its central users, and then it administers consent for the multiple providers that are part of that organization. It could evolve that way for the disparate program, which I'll talk about a little bit later, and there's lots and lots of discussion now that we've been operating under this model for a while of whether or not the laws in New York and federal and everything that I just described would support a consent where the patient does affirmatively consent, but might consent for all providers at one time and even all future providers who join the RIO, which is not currently allowed at all. So I think a lot of these models are under discussion, particularly as we talk about, I'll talk about a little bit later, we're moving towards more collaborative care programs. You really don't want consent to stand in the way of sharing among a whole care team and in a whole system that's trying to improve care together, but at the same time there are laws and regulations that we need to comply with. Okay, so let's move on to the next slide. So the next few minutes I'm going to do is to talk about some of the examples of how we've taken this technology and the policy woven together that I just described and have applied it in some of these forward-thinking initiatives where community-wide data is really necessary to meet their goals. And I'm going to talk about 5 different examples pretty quickly, and depending on where we go with Q&A later, maybe we'll get into some of the discussion even in more detail about them. The first one, next slide please, is an example of an insurance company that became a participant in HealthFix pretty recently. And they have very much from the start realized that health information exchange could really help them in the innovative way that they want to be a payer. And they really want to coordinate care for their members. So Oscar participates in the Health Insurance Exchange Program in New York and recently in New Jersey as well, and identified an opportunity that was really irksome to them, where their members have significant care events like ER visits or hospital admissions, and the health plan coordination department doesn't learn about it for weeks or months later. And sometimes the member has a very poor experience, and really they miss the opportunity to contribute to discharge planning and be involved in improving their care going forward. So what could they do about that? Next slide, please. So happily, Oscar integrated HealthFix into its everyday care routines, and in particular was very interested in receiving our clinical event notifications, which I described before, which because we have this data coming in from all of our providers in real time, we are able to, when we know and when what patients the participant is tracking and that they have consent for the patient, we're able to route consents in real time and let someone do something about it. So Oscar was very interested in making sure that their members were given the option to consent to HealthFix right at the get-go so that they could kind of open up the spigot for these events to flow. So when Oscar members open, join Oscar, they open an e-account where they do a lot of other administration of their membership in the plan, but they're also pushed information about our RIO, and they are given the option to consent on the state-approved consent form that we've embedded into the Oscar e-tool. And then when the events are able to flow, because we now understand and hear from Oscar through this tool that there's consent, we are able to send the event notifications, which are grabbed by the Oscar's nurse practitioner, who follows these events and actually intervenes. And I won't be able to go into too much detail today on what this looks like and how they do it. I'll show you a couple of slides in a moment. But we did a recent press conference with Oscar, which I think the video of the whole thing is posted on the HealthFix website at healthfix.org. And it's really impressive to actually hear from the nurse practitioner, the actual human being, who fields these events and sometimes jumps in a taxi or on the subway to go meet the patient at the emergency room to intervene. And that's when you realize the real power of these events for really changing the way care is delivered. Next slide, please. this is just a copy of what the e-tool consent, part of the e-tool consent form looks like. All of the verbiage of the state-approved form is on the site, and the members are given the choice, just like they are on a paper form, to say yes or no, so that OSCAR can get all of their data from HealthX, if there is other data on that patient in HealthX. Next slide, please. And this is another slide. I think there's more of that at the press conference that I mentioned and a lot more discussion over it. But in a recent 6-week period, we notified OSCAR of 66 hospital ER admissions, and they engaged 80% of those folks in different ways, as you can see here, by education or finding them specialists, solving some of their claims issues, referring them to different doctors or for their doctors on-call benefit so that they can call a teledoc. And so this really, they were very, very impressed that this is a kind of solution that's going to help them transform the way their insurance company does business. Next slide, please. Another example of a participant who used HealthX to its advantage was the Brooklyn Health Home. So the Brooklyn Health Home is formed as an independent entity, operating as a New York State Medicaid health home for over 8,000 and growing members who live in or receive care in Brooklyn. And they were initially started with a particular focus on patients with serious mental illness, but really are branching out as the health home program has really taken off. The Brooklyn Health Home independent entity comprises a network of lots of different kinds of organizations and community-based organizations, providers, nursing homes, so forth, working all together to coordinate care for Medicaid patients, and this is a model that we are seeing more and more and more of. And as part, really as defined by the health home program itself, but Brooklyn Health Home was very forward-thinking in trying to see how a connection with HealthX, the RIO, would be able to help them fix an opportunity that they identified of losing patients to follow-up care after they're hospitalized because there's insufficient communication among the extended care team members, and therefore there are preventable visits and hospital readmissions that happen. Next slide, please. I should just say, you know, the Brooklyn Health Home is not an ACO, but it feels a lot like an ACO. And I think that's kind of a theme that runs throughout what HealthX can support. We're doing a lot of ACO-like things, but our participants may not be termed ACOs, but there's, you know, everything sort of moving in that coordinated and accountable direction. So once the Brooklyn Health Home receives these events, again, subject to, in this case, health home consent for what I had called before the mothership, the Brooklyn Health Home uses these event notifications to drive care coordination with, again, human being care managers, which is really a lot of what the health home model supports, monitoring these events to enable timely communication and sharing information throughout the care transitions, both when the patient gets to the hospital or emergency room, also when the patient is discharged from the hospital. And in this case, the care manager would receive a HealthX alert, and it would trigger a set of care management activities, which they in turn have a whole dashboard tool that helps them along with that workflow, which involves things like notifying the PCP, following up with the member while they're in the hospital to learn a little bit more about it, certainly also checking the rest of the data in HealthX that now that they have consent, that they can see the rest of the history from HealthX, holding a case conference, following up with the member post-discharge to implement a care plan, and updating the care plan. So this is a whole cascade of events that happen really because of a real-time event from HealthX that really they might not know about if they were just waiting for a telephone call and the old-fashioned way of kind of doing that communication. Next slide, please. This slide just shows you that there have been increasing amounts of events over time that the health home obviously is collecting more and more consents to enable those events to flow. These involve ED visits, inpatient, and psychiatric admissions. We have now built an alert for incarceration events because there's a close connection here with the Brooklyn Health Home with patients that end up in correctional health at Rikers Island, and they really need to coordinate there. So that's been a very important alert for us to build into the process with them. There's clearly so much more to say about the Brooklyn Health Home, but this is just a little bit of an information. The Brooklyn Health Home also participated in that press conference, so you can hear more about them at that website that I gave you. Okay, next slide, please. All right, so we clearly don't have so much time to talk in detail about the disparate program, the Delivery System Reform Incentive Payment Program, but for those of you in New York and other states that are implementing this kind of program, this is a huge transformative opportunity in healthcare. It's an unparalleled amount of, historic amount of money, $6.4 billion in funding for providers to really transform the way the New York State healthcare delivery system works and to start incentivizing value over volume. So this, of course, is the kind of program that makes the health information exchanges heartbeat so much faster and happier, because this is exactly the kind of program that we're built and our mission is meant to support. So each disparate program will be led by our Performing Provider System, a PPS, which in turn includes a whole variety of clinical partners, many of whom are already independently members of our RIO and other RIOs, and many of whom, I would say most of whom, unfortunately, yet are not. But collaboratively, they will implement each PPS project selected from a menu set that are meant to address findings of community needs assessments that they did, and over time be rewarded for achieving specific performance levels and outcomes. So this is exactly the kind of program that is in need of community-wide data to help their workflows do the best outcomes management that they can. So of course New York wants to leverage the huge investments in health information exchange, and in particular RIOs, to support the disparate goals and to meet the expectation of using this innovative and evidence-based type of care across all of their communities. Next slide, please. So of the 25 emerging PPSs that were announced after the December 22nd applications went in, 8 of them, so about a third of them, are working with HealthX here in the downstate area. This is a huge opportunity for us, and I guess this slide really just shows you how much all of this planning and implementation is ahead of us. We are really now in discussions with these PPSs about which partners they're going to recruit into HealthX, which ones are their high priority partners that really need to have their data flowing into HealthX, and some of that is mandated by the application itself. And sometimes if the PPSs are going to form their own independent entity, yet another kind of mothership like I talked about before, it may be very necessary if they are going to deploy IT solutions of their own to integrate that solution, that coordinated central solution into HealthX, so that we get the benefit of the data that they're coordinating centrally and can share it with their partners, but importantly, also so that we can share it with the other PPSs in our area and even other RIOs areas, because even in New York City, there are other PPSs that are hooked up to different RIOs. So this really highlights the need for cross-RIO interoperability, because the disparate program really has everyone rising and falling together. So it's really pushing this notion of interoperability. We want to ensure that all of the functions that I talked about earlier, patient record lookup and clinical event notifications and messaging, are used by each PPS in a way that maximizes utility for their own projects, using their own IT from either their partners or a central deployment. And we're really just starting to get into the discussions and consulting and understanding with them how they're going to all do that. One of the important things will be to create panels of patients, and how consent will work. But a lot of these things are still under discussion, and you know, there's been a lot of discussion about whether the PPSs will even get a list of the patients that are attributed to them. We believe that they will be getting that, although it was sort of unclear at the start of the program, but it's not yet clear that that list will be able to be shared with the RIOs, or at least not yet. And so you can imagine the kind of complication that that will cause if the RIO isn't able to understand the universe of patients that a PPS cares about, so that we can't, you know, really help them understand their universe either through collecting consent for them or analytics on a particular population. So there's just a lot of really ripe issues for us to all work on together with respect to DISRIP, and it's really just starting, but it's very exciting. Next slide, please. Okay, the next couple of slides are very different kinds of projects that HealthX is supporting. I'm going to go pretty quickly because I know we want to leave time for questions here. But one of the projects is called the Query Health Project that we're just starting now. And this is a precursor to public health access to data, which doesn't require consent for population health and surveillance activities. But we're not quite sure yet whether or not the data in HealthX can be used and can be used in a database that would support this kind of work. And so there was some Medicaid grant funding that just became available through the New York eHealth Collaborative, or NICE, to develop and test some systems that ultimately could enable public health agencies to perform their public health functions. But right now, the question still is internal to the RIO, can the data even be used to support this? So with the help of entering into a whole series of agreements and having our committees review this like I described before, we're getting to the point, next slide please, where we have a first phase of a grant project, which we're embarking on right now, which is really meant to assess the quality of the data in HealthX. What we're going to do is to create about 1 million CCDs that we do from aggregating our data, and then take it into a separate server where folks from the Department of Health and Mental Hygiene here in New York City, in this case acting as agents of us instead of as public health practitioners, because we're not really at the public health use point yet, we're really just at the RIO doing this analysis, will be granted secure remote access to these CCDs, and they'll be creating an I2B2 instance, which is a research database format, the informatics for integrating biology in the bedside from Partners Healthcare in Massachusetts. So this standard, which is used a lot in research, but we're going to be taking our data, transforming it into that instance, and testing the ability of that database to derive analysis of our data. Will it be good enough data, or at least let us get some information on how the data needs to be augmented, transformed, so that these types of population health uses can ultimately be supported. And this sort of speaks to other types of analytics that we'll also need to do as well besides public health. Here's what the technical approach to what I just talked about. We haven't been real technical today, so I won't dwell on it, but there it is for you. And finally, the next slide, please. I just wanted to spend a minute talking about the New York City Clinical Data Research Network project, which is so exciting, a project under PCORI, the Patient-Centered Outcomes Research Institute. And the stakeholders in the New York PCORI project include many academic medical centers and FQHCs in the city. This is a national effort. I'm sure many of you on the line are participating in other projects, either in New York or elsewhere, that are part of PCORI. But in this case, the CDRN group wanted to facilitate research between and among these stakeholders, but in a way that minimized, again, further warehousing of identifiable data, which, as we just heard, is a lot of which is already in HealthX. So how could they use technology that already existed from HealthX, already a trusted partner, to support this project? Next slide, please. So what they did in the CDRN project, and we've now just completed the first phase of this, is after lots and lots of discussion of many different committees, both within the RIO, within the CDRN, IRBs, and so forth, we figured out a way to leverage the Master Person Index of HealthX, which links patients' records from multiple providers, but also link patients from the Bronx RIO, one of the other RIOs in the state, but only do so in a way that sends de-identified linkages to CDRN's other trusted agent, the New York Genome Center, by using proxy IDs. And in turn, then, the participants can send their de-identified data, because they're also using date shift values, to the Genome Center, which is then able to be linked and aggregated from multiple providers, even though it is de-identified, because they're having the proxy ID linkages that come from HealthX. So this is an incredibly involved process here, and the next slide, and my last slide, shows a lot of the data flow for what this is going to look like. And if this has whet your appetite for more information about the CDRN, I would just note that the HealthX President and CEO, Tom Check, will be speaking at the HIMSS conference this year on Thursday, April 16th from 12 to 1 p.m. about this exact topic, and they'll have a whole hour to talk about it. So it'll be much more than I'm able to cover today. So with that, and I know that's a lot, I'm going to turn it back over to Trish, and hopefully we can get some questions going.
Yeah, thank you, Irene. And we do have a couple of questions. Just to remind people, if you have a question, you can type it into the question box which should be showing on your screen, and we'll try to get to as many as possible. I guess the first one I'm going to initially direct to Lee, but then maybe ask Irene to weigh in, given her regional experience. The question is, Lee, do you really, maybe I'll phrase it a little differently, do you think it's feasible that a national exchange model we're going to be able to achieve a national exchange model that takes into account all the interoperability, necessity, the scalability, the privacy, the security, all of those requirements? And do you see, what are the significant challenges you see?
Well, so Trish, good question. I think, and it's probably the big question is how is this going to happen, and can it happen? I think the answer is that it will happen. I think it's going to take some time. I do think that, as I was talking about, the roadmap that ONC has, in fact, laid out and is laying out and is looking to really finalize by March of this year will really provide that roadmap and kind of how we can look to do this in a incremental way, and that's going to be the key. Now, there are a lot of challenges with it, and I think as you were asking, what are some of those challenges? I think challenge one is certainly getting all the stakeholders, including the providers, to adopt and to actually use all of these capabilities and getting them. Now, we've seen significant evolution, and I think meaningful use has helped a lot here in some of the incentives that ONC has put together for EHR adoption, and I think we've seen some significant adoption on the part of the providers and the practices, the group practices to adopt EHRs. That's been a big piece of this. I think being able to leverage a lot of the capabilities that are in some of these are still a challenge that has to occur. And I think as well, I think the vendors as well, we need to see the vendors continuing to adopt and to develop tools and services and products that are interoperable, that provide the scalability, and can integrate with really existing systems and existing technology that organizations have. The one thing that a lot of organizations don't want to have to do is to completely throw out the technology that they've invested heavily into for perhaps many years. So I think that's the other real challenge here is to be able to build that scalability, build the ability for organizations to continue to build upon it and integrate with existing systems. And then you've got a lot of these hospitals who still have a number of different interfaces. I mean, I have hospitals that I talk to that have over 100 different interfaces with various types of technology, with its radiological equipment, other types of imaging that they're trying to manage. Those are the types of challenges that are still there that I think over time we will get there, and I think, but we've got the challenges that will continue to evolve here. But I do think that the roadmap will be important, I think, for the industry to look to adopt and to put together, I think, their own plans in an effort to execute against.
Irene, I'm going to ask you the same. Just based on your experience in New York, are there other additional hurdles that you think need to be overcome, or?
I think the trust model and the agreements that put that in place there's some models put in place now and they're evolving over time, but what we find in New York, because our consent model, which I talked about, is a little different and more restrictive, frankly, or sort of reverse from a lot of different models which relate to consent to disclosure, there has to be a harmonization of those policies, and since state laws are really different, it just may be difficult to slog through it, but we're going to need to do that to make sure that the scalability can happen.
Yeah, and this next question maybe dovetails right into that because, as I'm sure everyone is aware, everybody's getting into the personal health space either through a Fitbit or an Apple Watch or some other health app or personal health record. Irene, how do you see that information, or do you see that information ever making its way into an HIE, or should it?
Yes, very much so. There is definitely a lot of discussion in New York, and it's not, there are actually some components of the shiny privacy policies that do relate to personal data and personal access by patients to the data in the shiny. And we're taking it here a little bit slow. A lot of our constituents have deployed personal health records in connection with meaningful use and so forth, and that's only going to get more and more prevalent. The issue when it comes to hooking up those kinds of things to health information exchange that we haven't totally nailed yet, and there's still a lot of discussion about this statewide in New York, centers around a couple things. One is making sure that we have really solid standards for patient authentication. You don't want to be releasing a whole community-wide of data on a patient that we've linked together to the wrong person. So we need to make sure that the identification of the patient is pretty airtight, and it's a different process than with providers. And then, there have been also some concerns about we want to share as much data as possible with patients. I think we're very much in an arc towards having maximum access for patients, but there really are some laws that we need to grapple with here in the state that do limit what some patients can see or the timing under which they can see it, like the HIV test results law and some other laws that I'm familiar with in psych, where sometimes seeing data can be harmful to a patient. So how do we sort of build that into a process where an app can just hook in to a health information exchange? But having said that, we'll get over those barriers, and I see that so much more accessibility to data on mobile devices and stuff will only grow and grow think patients will be able to log consents in a much more granular way than we have right now, and that will really change the way our technology works and the way we think about, you know, integrating them into their care.
Thanks. One more, I guess this one will direct to Lee. Are there other health exchange models being developed or that need to be developed? And then I guess maybe just following up to the first question, you know, if that occurs, you know, how do we make sure there's still the overall plan to make a national integrated model?
So another good question, Trish. I think that, first of all, what we have right now is, and you know, between Irene and myself talking about all the various models that are currently out there, whether it's the RIOs, the HIOs, the HIEs, the ACOs, there's a lot of different models, and there's a lot of different payment models as well that are proliferating. I think, you know, we're going to continue to see the models evolve. We're going to continue to see more, I think, risk-based models that are being put in place, and I think we're going to see a lot more in which consumers, patients are going to need to as well take on more responsibility, and it's going to be really shared responsibility amongst, you know, all the various stakeholders here. So I think we're going to continue to see evolution in the models. What we call today as an ACO, we may morph into another name in the next 2 to 5 years, as well as the HIEs. I think as we get more adoption, as Irene talked about, the whole consent aspect, the whole aspect of mobile technology and various apps. And I think as we look to address some of the issues around security, privacy, and confidentiality of the data exchange, so the answer is we're going to continue to see evolution on the models. I think the roadmap that ONC is laying out through 2020 and perhaps even beyond will help in relation to creating an architecture and really a set of challenges that each of the stakeholders needs to put in place and execute against in an effort to see it evolve. And I think that's what we're going to do, and I think having ONC kind of lay this out next week in D.C. and over the next couple of months as they roll this out in March will be important as we continue, all of us, continue to help to make it happen and evolve it.
Thank you. Maybe we have time for one more, which I will direct Irene. I know I've actually heard this before as well. Sometimes providers are concerned that with a health information exchange, they're getting way too much information and they don't have time to sort through it. I guess I'd ask for your comment on that, Irene, although as I was listening to your presentation, it's interesting. It looks like some of the organizations you're partnering with have really figured out how to focus on that and provide a care manager to maybe help facilitate the process so the information is not overwhelming.
Yeah, not only have they devoted human beings to sort of be the human router, but then the stuff that they pass along and sort of ingest into the field of their workflow tool is a very small subset of the RIO data. Sometimes, you know, that's certainly the case in the Brooklyn Health Home, so that's one way of doing it. But I think we'll see a lot of efforts in the future to sort of limit either by time frame or types of data or sources of data for different types of recipients, which data they see so that it can be most actionable. But of course, you're always going to be in the backdrop of an evolving landscape and maybe evolving standard of care of how much data needs to go where and when, and we're just really at the beginning of being able to even talk about that, much less have answers about it, but I think it's a very relevant question that we will continue to really hear a lot about. Having said that, you know, the data's always been there. The data, if you're a provider and you're looking to get to do coordinated care, it's always been there if you call up other providers or have them fax it to you. I think what's new here is that there is a lot of data accessible at once, and your question is really relevant. How do you, know which piece of it to look at? And I think we'll just see a lot more slicing and dicing over time.
Yeah, which is a topic for a whole different seminar or webinar. We're out of time. I want to thank everybody for joining us today. I want to especially thank Lee and Irene for their presentations, excellent thoughts, and an exciting field, a lot to do, but a lot already has happened.
Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.